Good morning. I'm David Cohen from St. Luke's Mid-America Heart Institute in Kansas City, and I'm joined by my colleagues Dominick Angiolillo from the University of Florida in Jacksonville and Tullio Palmerini from Bologna, and we're going to be discussing non-vitamin K antagonist oral anticoagulants, the NOACs, or the DOACs as they're now called, in atherosclerotic cardiovascular disease. As we all know, these drugs were originally developed for atrial fibrillation, but they are finding new ways to improve the health of our patients, and we're talking about that this morning. The first topic we're really going to be covering is atrial fibrillation and PCI, which is a very challenging area. Atrial fibrillation still is about somewhere around 8% of all patients who undergo PCI have atrial fibrillation, an indication for oral anticoagulation. And we have a number of different approaches for dealing with them these days. The AHA and ACC have recently updated some of their guidelines, recommending keeping the triple duration, the triple therapy, oral anticoagulant plus dual antiplatelet therapy, as short as possible, using low-dose aspirin, favoring clopidogrel as the P2Y12 inhibitor of choice for its lower bleeding risk, and targeting a relatively low INR. And then they recommend considering dual therapy, an oral anticoagulant plus clopidogrel in selected patients, and we'll talk more about that. The ESC has perhaps a similar type of approach. They recommend, as with so many things these days, balancing the risk and benefit. If the bleeding risk is low relative to the risk of ACS or stent thrombosis, then a extended period of dual antiplatelet therapy with a very short period of triple therapy. If the bleeding risk is high, on the other hand, again, a short period of triple therapy followed by 3 to 6 months of dual antiplatelet therapy, finally ultimately transitioning to oral anticoagulant monotherapy. So many interesting nuances here to discuss. How long, if at all, to give triple therapy? What do we do when we're done with the dual therapy? A lot of this goes back to the WOS trial, which was really a landmark trial that I think surprised many of us, done now about 5 years ago. About 570 patients with either atrial fibrillation or another indication for oral anticoagulation. Many of these patients had DVT or PE as well, who were randomized to a triple therapy group using warfarin, clopidogrel, and aspirin, and a double therapy group, which was simply warfarin plus clopidogrel. As we know, there was a marked reduction in bleeding, more than a halving of the risk of bleeding, and also a very reassuring reduction, actually, in the ischemic endpoint of death, MI stroke, stent thrombosis, and target vessel revascularization. So this was a trial, one of the few trials that we seem to run in the anticoagulation space where there was a free lunch. We got better bleeding risk and better ischemic outcomes. That's not been the story since then. Following on the heels of the WOS trial have been a number of trials that are either completed or now enrolling, looking at atrial fibrillation plus PCI with the NOACs. So the first one that was done was the Pioneer AF PCI trial that Mike Gibson led. This was a trial using rivaroxaban. There were actually 3 different anticoagulant regimens that were studied, but the standard one was triple therapy, warfarin, aspirin, and clopidogrel. Rivaroxaban, kind of medium dose, 15 milligrams q.day with a P2Y12 inhibitor, and then there was actually a third dose with very low dose rivaroxaban, 2.5 twice daily, low dose aspirin, and a P2Y12 inhibitor. And both of the rivaroxaban doses approaches lowered the bleeding risk with no major difference in ischemic endpoints. This was followed by the ReDual PCI trial with dabigatran, led by Chris Cannon, a little bit larger trial, but a very similar type of population. This also had 3 regimens: standard triple therapy with warfarin, dabigatran 110 milligrams twice daily, the sort of high bleeding risk dose with a P2Y12 inhibitor, and then also dabigatran 150 milligrams twice daily with the P2Y12 inhibitor. Both of the dabigatran dual therapy doses reduced bleeding, and the ischemic complications were fairly similar, although there was a kind of worrisome trend, I would say, with the 110 milligram dabigatran dose. There are 2 other trials which are ongoing: the Entrust AF trial with edoxaban, and then probably the most interesting of the 4 trials, the Augustus trial, which is being done with apixaban, which is actually a 2x2 factorial design trial looking at apixaban versus warfarin and low-dose aspirin versus not. So this will be the first trial that really will actually compare a NOAC versus warfarin specifically without modifying any of the other agents. So that's kind of our landscape here. And I think we should stop now and just talk a little bit about what do we do with the atrial fibrillation patient. We all see them. We all struggle a little bit, although I think we're getting more and more consensus. So Dominick, we were just chatting beforehand, and you said you're working on yet another consensus document that you can't really share with us, but you've obviously been thinking about this quite a bit.
Sure. Well, clearly now with the release of both Pioneer and Redual, with very consistent findings from the VOOS trial, we really need to think about the whole concept of triple therapy. There's a lot of consistency, and the take-home message from the trials and from the meta-analysis that derived from the trials is that a double antithrombotic therapy is the treatment of choice. There's still a lot of concerns about dropping aspirin that early, but this was what was done in the trial. And there was no rebound in clinical events, stent thrombosis, and I think that should be the strategy of choice.
So the meta-analysis, I think, just came out last week. The one, at least I saw one, just came out last week.
There are a number that came out. There was one that came out in New England by Piccini. There was a little bit of an error there. They had to recorrect that. But now it's the information that's out there. It's correct. But there's a series of other ones that were published. One from Patti and Cavallari in the American Journal of Cardiology, and another one that Deepak Bhatt led as well in European.
So there's certainly been a bunch of them. And again, the consistent theme is dropping aspirin seems okay. What about the ischemic risk side of things? I mean, it's very clear that dropping aspirin lowers the bleeding risk. That's not a question at this point. But none of the trials, and not even the meta-analysis, are really powered to look at the stent thrombosis endpoint. And I think all of us worry, at least a little bit, about dropping aspirin when you're using clopidogrel as the P2Y12 inhibitor, because we know there are patients who are resistant to clopidogrel.
Yeah, there is that concern, obviously. But one of the things to keep in mind, there are a few things to keep in mind. We'll never have another trial again powered for stent thrombosis because the rates are so low. And we've come a long way in this field also because we have much better stents. We tend to omit that comment, but that's so important. The other thing to keep in mind is that this is not dropping aspirin and just leaving the patient on clopidogrel alone. You also have an anticoagulant. And one thing that we know about anticoagulants is that they also have some indirect antiplatelet effects. Let's take, for example, an anti-10. An anti-10 modulates the generation of thrombin. Thrombin obviously has an impact on fibrin strands, but at the same time, thrombin is the main inducer of platelets. So there's a lot going on, and so
we shouldn't worry so much, perhaps, because we have a good antithrombin.
Exactly. And there's some synergism also between antiplatelets and anticoagulants. That's the reason why stopping aspirin, in my opinion, is
might be a good one. So let's go. What is your take on the data, Tullio? What are you doing in Italy these days?
Well, actually, I'm still concerned about giving just a dual antiplatelet therapy to a patient with a stent, because there are signals that if you do dual antiplatelet therapy, the risk of stent thrombosis may be higher. This was true both in the Pioneer study, and this was true also in the Redual trial if you look at the lower dose of the bigatran.
Yeah.
So I'm not ready yet to give dual antiplatelet therapy to all my patients with in which I put a stent. But
you mean single antiplatelet therapy?
Yes. Okay. Yes. But to me, this is the time to stratify patients, to select those who are at higher risk of stent thrombosis, and these are the patients in whom I still give triple antiplatelet therapy. Whereas, if I have a very simple procedure, very low risk of stent thrombosis, and the patient has a high risk of bleeding, I give him dual antiplatelet therapy.
You give triple therapy there?
Double therapy, yeah.
So if you were giving aspirin, that's really what we're talking about, is giving aspirin in a patient with atrial fibrillation. So you're going to give an anticoagulant. You're going to give a P2Y12 inhibitor, probably clopidogrel in that case. And then the real question is just aspirin at all, And if so, for how long? So if you were doing that, you have a patient, you're much more worried about thrombosis than bleeding. How long will you give the aspirin?
Well, I think for at least 3 months. I mean, in patients at high risk of stent thrombosis. And then actually, I would rather prefer to drop clopidogrel rather than aspirin. And that's because if you drop aspirin and the patient is resistant to clopidogrel, has a poor responsiveness to clopidogrel, this patient is only on anticoagulant therapy in still a critical period, because within the first year, this is still a critical period for stent thrombosis.
So what do you think of? I see the hairs on the back of your neck standing up, Dominic. After the discussion we had this morning.
I agree with the first part of the conversation, and even in our working group, I can't go into the details, but you'll see in the document we allow for patients at high thrombotic risk, a lot of stents where there are concerns to consider keeping that aspirin on board for a month.
Okay.
But we had a huge debate on this aspect of, well, if you drop aspirin and the patient's resistant to clopidogrel, what happens? Obviously, it is a concern. But if it would be such a concern, we would have seen very, very high rates of stent thrombosis in the VOOST, REDUAL, and PIONEER, and it was not seen. Stent thrombosis rates were no higher than 1%, maybe it was 1.1% in one of the studies. So there's a certain level of reassurance. Now, having said that, as a person who believes in resistance and whatnot, at our center, we do genetic testing in all our patients. It's part of a large NIH a study where the study is actually implementing clinically genetic testing. And we can do it with a buccal swab. We get results in less than an hour, and put in our electronic medical record. So it really implemented as standard of care. It's in the electronic medical record, and you can use the information just like you're using a CBC, for example.
So you know if your patient has a STAR 2 or something like that.
Exactly. So that helps. Now, if the patient is a STAR 2, obviously I'm not going to keep the patient on clopidogrel. I'll put that patient on ticagrelor. We have some data from the REDUAL trial, 10% of patients that were on ticagrelor. It's just a small group, but again, if you have a patient who has low risk of bleeding, high thrombotic risk, that's also a strategy.
So, well, I mean, if you look at the data of the PIONEER in patients that did the dual antiplatelet therapy for 1 month, so the rates of stent thrombosis was 1.9%, and this is not low.
No.
So I think this is a concern.
It certainly is a concern.
And of course, I mean, these are trial of 1,500 patients, 2,000 patients, so it's not enough to be sure that this regimen is safe for stent thrombosis.
Yeah, no, I mean, I certainly accept that. I mean, the confidence intervals on stent thrombosis, even in the meta-analyses, are still wider than one would like. I think that's absolutely the case. The one thing that I think is really pretty clear is if you don't drop the aspirin, you don't get the bleeding reduction. If you look at the data from REDUAL. So REDUAL, in the triple therapy group, the aspirin was only given for 1 to 3 months. 1 month for the bare metal stents, 3 months for the drug-eluting stents. And if you look at the curves for bleeding, they basically stop separating as soon as the aspirin goes away. Mm-hmm. So you're not getting any of you don't get a lot of benefit of stopping the aspirin unless you stop the aspirin. Yeah. I guess is the point.
Probably the other consideration that we should make, for example, in the PIONEER, major bleeding were not reduced. So, and on the other hand, if you don't reduce major bleeding, but you increase the risk of stent thrombosis, that may be a disaster.
So it's still a trade-off in your mind.
Yeah.
Here, risk and benefit and things like that. I mean, it's going to be, it will be tough for a while because we're not going to have a definitive answer. We're not going to have a stent thrombosis powered trial. We will have to settle for meta-analyses of these 4 NOAC trials plus WOOST as probably the best, the best way we're going to get an answer there. We will have at that point about at least 10,000 or so patients total randomized, but it's probably still not enough to really answer the question. I think it needs a 40,000 patient trial or something like that
which we're never going to
if you work that all out. Well, let's switch gears for a little bit and talk about the other exciting area for antithrombotic therapy, and that's what do we do in stable coronary disease. We obviously know there are a number of things that we want to talk about. In particular, let's start with the guidelines. So the guidelines talk about antiplatelet therapy in stable coronary disease. Aspirin is the mainstay. It's been forever the mainstay in stable coronary disease. Either aspirin or clopidogrel alone, based on the Pci trial from many, many years ago. And then for patients who are post-myocardial infarction, both the ESC and the ACC-AHA give a 2B recommendation to adding ticagrelor. Presumably that's on the basis of the Pegasus trial. So let's look at some of these data. So here is the Pegasus trial, which really was the first trial to show that addition of a P2Y12 inhibitor on top of standard therapy, including low-dose aspirin, improved ischemic outcomes in patients with a prior myocardial infarction. There was the Charisma trial before this, was a negative trial overall with a positive subgroup. But this was the first overall positive trial, which showed that both the 90 and the 60 milligram dose twice daily of ticagrelor led to about a 15 to 18% relative risk reduction in the risk of death, CV death, MI, or stroke. So again, a modest but important benefit for our patients, but with a very important caveat, which is a counterbalancing increased risk of bleeding complications. And as we heard at our session this morning, I don't think any of the presenters this morning said, they all said there's a price to pay. Every time this came up, there's a price to pay. We have not yet found an anticoagulant or an antiplatelet drug that doesn't increase bleeding if it's working. And here again, there was a substantial increase in TIMI major bleeding and TIMI minor bleeding, no changes in fatal bleeding, and no overall difference in all-cause mortality in the Pegasus trial. That was a couple of years ago, and then this summer we had this big blockbuster, the Compass trial. And the Compass trial looked at a similar population. This was patients with either coronary disease or peripheral artery disease. And in this case, the randomization was 3 ways: low-dose aspirin, standard of care; a low-ish dose of rivaroxaban, 5 milligrams twice daily; and then the very low-dose rivaroxaban, 2.5 milligrams twice daily, along with low-dose aspirin. And the trial was stopped early at about 1,000, about half of its intended events, because of overwhelming efficacy in the rivaroxaban plus low-dose aspirin group, which included very important reductions in cardiovascular death, stroke, and all-cause mortality, but an increased risk, again, of major bleeding, although they did have a net outcome when they sort of parsed out the major bleeding, and were able to suggest at least there was still a net positive benefit. But again, I think a very striking trial, both for the fact that it was stopped early, for the magnitude, about a 20% relative risk reduction in the primary endpoint, and then I think really what's made everybody so excited about it is the all-cause mortality reduction, which comes on the heels of similar findings with that low-dose rivaroxaban and aspirin group in the Atlas TIMI 51 trial. So again, a very, very provocative trial. And so let's talk now specifically about stable coronary disease, the post-MI patient, the patient with peripheral artery disease. We all have these patients in our clinic. Most of them are on aspirin at this point. Some of them are on dual antiplatelet therapy because we're afraid for whatever reason to stop clopidogrel, or we're giving them ticagrelor. What are we going to do now? Now we have too many choices. So Tullio, Dominick went first last time, so let me let you get at it first here.
Well, actually, I think that the results of the Compass trial are really impressive because of the reduction of mortality. Even though this was not the primary endpoint of the study, I think it's a credible finding because this is something that we saw also in Atlas ACS. And I think there is something about the dose, because if you look at the higher dose, 5 milligram twice a day, there was no reduction in mortality in both trials.
Yeah.
Whereas in both trials, with the lower dose of rivaroxaban, there was really a decrease in mortality. So I think that these trials together have the potential to change our clinical practice.
Do you think in Italy there will be reimbursement for this drug? It's probably going to be expensive.
Well, that's a difficult question.
Yeah. I mean, if you were the government, would you pay for it?
Oh, I think so. Yeah.
Okay. That's obviously going to be very important, especially in countries with, with single-payer healthcare. like most of the countries in
I
Europe.
mean, when you have a trial in which you see a difference in mortality, which is convincing, I mean, this should change your clinical practice.
So we should be, I mean, and I think, as you already emphasized, one of the things that convinces you very much about it is the fact that it's the second trial
Yes.
in which this was shown. Because I think that if it was just one trial, you might say,
Absolutely.
Could be a fluke.
And I think it's consistent also the concept regarding the dose. For example, if you go back to the Pci Trial with apixaban,
right. Nothing there, no benefit.
Yeah, there was no benefit, but there, in the Pci Trial, they used the higher dose of apixaban. So the trial was stopped early because there was an increase of bleeding and no effect on ischemic events.
Right.
So I think that the combination of antiplatelet therapy and a low dose of anticoagulant therapy may be the way to go.
Maybe the way to go. So Dominic?
Yeah, so I'll expand a little bit on what Tullio said. I think, Compass was a great trial. And where it won was clearly on identifying the right dose. I've been part of the trial development programs now for a number of years, and they've done a very, very good job in their dose finding studies, something that cannot be said about some of the other NOACs. Definitely there's something there. There's something there about the synergism with the very low dose, which is now called vascular dose.
Oh, they have a name for it.
This is a name for it.
Okay.
Vascular
Still can't
dose.
buy it though, right?
You still can't buy it. Plus aspirin. But let's go now to the practical part. I think in PAD, it's a slam dunk. I mean, it is the best clinical trial data that we've had in PAD ever. The only thing that came close was with Vorpaxar,
which nobody used.
Which nobody uses, but again, you didn't have the mortality benefit and whatnot. So here you have something that that's going to be very easy because a lot of these patients may be on aspirin alone. It's just adding. The CAD becomes a little bit complex, and let me explain to you why. And here I'm playing the devil's advocate.
No, it's important to have a debate.
The mean time from when the patient may have had an MI was around 7 years. So you may have a patient in your practice who is 7 years from their MI, doing perfectly fine on aspirin alone. So the question becomes, how do you explain to that patient, I'm going to add a drug that you're going to have to take twice daily and may increase
for the rest of your
life. There may be a cost and may increase your risk of bleeding. So I think, both the patient and the physician may struggle a little bit with that. I think the turning point is really going to be at the end of when people stop their dual antiplatelet therapy and there's a decision making. I think in real world clinical practice. Now, these were not the patients how they were enrolled in the trial, but ultimately this is the way I believe that there may be some type of a pickup in the use of this strategy.
Right.
You're at 1 year, you need to decide, do I stop DAPT, do I continue with DAPT, or do I change strategy? I think that's what's probably going to happen.
I think, it would have been so much simpler, that was the hope of something like Pegasus was you wouldn't have to stop at all. You just change the dose and off you go down there. But these data are more striking than Pegasus in some ways.
I agree 100% with Dominic. But should psychological issues from the side of the doctor and the side of the patient preclude us to give a therapy which has been shown to be so effective? So I understand the point that you have difficulties to explain to a patient who is doing well that now he has to undergo another therapy with potentially high risk of bleeding. I mean, if you explain to the patient that it's likely that this therapy is going to prolong his survival, it's not,
and prevent stroke.
Yeah,
which most patients are very afraid of, and physicians don't like either.
But what I do think, and the Compass investigators, they're working on this, but there's an obligation to better define who are the bleeders and who are the patients who achieve the greatest ischemic benefit. Because, like all new treatments, we're not going to be using it in everybody. And so identifying the patients with greatest benefit will be the first stepping stone, in my opinion.
Well, I think we know from other studies who the patients are who have the highest ischemic risk. And that's polyvascular disease, right? If you have every bed that you add coronary, cerebral, peripheral, adds substantial risk. And so that's a pretty easy formula to follow. Once they've got two vascular beds, and certainly when they have three, the addition of something makes sense. And again, given these data, I would say the something probably now ought to be very low dose rivaroxaban. The interesting question that we raised this morning is, do they have the antiplatelet therapy right? Is aspirin the right antiplatelet therapy, or should it be clopidogrel, which head-to-head trials in the absence of rivaroxaban showed better ischemic outcomes and lower bleeding, right? The Capri trial a long time ago showed us that.
Yeah. My personal opinion is I would love to see a trial with a P2Y12 inhibitor. The answer is yes. We know that aspirin is associated with GI bleed. Had the trial be done with a drug like clopidogrel, maybe there would be even less bleed, but we don't know. Let's not forget that in COMPASS we do have the 2x2 design where you the pantoprazole arm. So we will see. I mean, there'll be something if that helps.
Yeah. No, it certainly is fascinating. It's endlessly complicated. I guess these days we keep thinking we could make it simpler. I don't know why. So why can't we make it simpler, Tullio? What is the problem here?
Making it simpler, sorry?
Our decisions. It's because it feels like it's just becoming. When I started in interventional cardiology, it was simple. You put in a stent, you gave aspirin, and you gave ticlopidine for a month. And then you stopped the ticlopidine, and they took a statin or something like that. There was no, and they stayed on their aspirin. Everything was simple. Now we have so many choices.
Yeah, there are many trials, many options. So, and sometimes it's difficult to integrate all this information.
I think it does get that way. It feels that way. Yeah. We're going to certainly have to learn a lot more about the NOACs. Again, I think most of us are reasonably familiar with them for taking care of patients with atrial fibrillation. But this vascular dose rivaroxaban is a special dose.
Yeah, and the other issue is not getting the primary care doctors or the patients confused with all these doses that are out there. This is something that we're going to have to deal with and have to pay a lot of attention. When our patients come into our clinics and when we're looking at their meds, and
it sure would be nice if rivaroxaban was not twice daily. It's twice daily drugs are not so easy to take for the rest of your life.
But there's a very strong rationale behind that.
The pharmacology.
The pharmacology, more specifically the pharmacokinetic aspect, because when you look at the exposure or the half-life of the 2.5 milligram, it's around 5 hours.
Okay.
So essentially by 12 hours you have almost no drug. So you have to give it twice daily. There is no other way.
I know what you mean.
And you can't give it 5 milligram, because 5 milligram, the half-life is slightly less than 7 hours. Around 7 hours. So you have the same problem.
Yeah, okay. So
that's why I have to go twice daily. This was very well looked into.
Some people, I've heard people say that they think that the 20 milligram once daily dose for AFib is not right, actually. It's not it's not, because it really is a twice daily drug.
Well, there's a lot of debate surrounding that. When you look at the PK analysis, it does cover the 24 hours. Now, clearly, the trough aspect, it really goes down, and this is kind of a little bit some of the debates we've been having, for example, with a Pixaban, where they're kind of similar profiles. In their clinical trial development, they decided to go BID, while Riva decided to go once daily with AFib. But when you go down with the dose, clearly you need the twice daily.
I guess the other thing that we're probably never going to have a real great answer to is choosing among the NOACs and the AFib patients. We talked already, we're just going back to the AFib, and we said we'll get rid of the aspirin. That's, everybody agrees, some point you got to get rid of the aspirin. Which one you choose? Again, these days that's kind of dealer's choice. We don't have data yet on apixaban or edoxaban. I know a lot of doctors, certainly apixaban gets a lot of use. In my hospital, it's very popular, and so we have already adopted those strategies. But
yeah, my hospital, actually, we get more use of rivaroxaban because of the once daily. I deal more with a less compliant patient population, so having the once daily is a great thing. I have the option of both the 20 milligram and the 15 milligram. So that's what happens at our place, and our patients have a little bit better access to it. But as you mentioned, not necessarily because of outcomes. It just
Efficacy,
was
it's convenience, what's on the formulary.
Exactly.
Do you have access to all of the different NOACs in Italy now?
Yes, absolutely. Yeah.
So in
AFib, I mean, again, there are no studies that have compared each other this drug. So I don't think there are scientific reason to prefer one or the other. In my place, we use a lot of apixaban. Yeah.
I think it's popular, but I think it's important to know how to use them all because they have different side effects and they may have nuances for certain patients. Well, I think it's been a great discussion. Our time is up. The clock is yelling at me for that. And again, I want to thank both Dominick and Tullio for a wonderful discussion, really opening up all these issues that we're going to have to wrestle with for many years to come. And thank you all for joining us. Have a great day.
Thanks.
Thank you.